Good evening. I am Maarten Termeer from the University Medical Center from Rotterdam. At the end of December, I gave an initial webinar on the basic principles how to evaluate a liver MRI. Often it is a combination of different findings that will help you to make a definitive diagnosis. They can be, for instance, the presence of blood, fat, washout. In daily practice, we seldom need biopsy or for pathological proof. Most therapies are based on our imaging diagnosis. And I think this is also the case in most tertiary liver centers. I will present this session together with Mira Kuipers, which is a very promising third-year resident with abdominal differentiation at the department. I will first give an introduction on the use of contrast agents in liver MRI. This will be followed by a new kind of case-based discussion where we want to copy daily supervision as much as possible. Mira will go through 2 new cases, and I will answer all of her questions as far as possible, of course, and I will give her feedback. I hope you will like this new form of case-based supervised webinar. The aim of this session will be to give a short overview of the basic principles of contrast-enhanced liver MRI. I will explain the different possible scan phases, the behavior of liver tumors during the different phases, and I will explain the current trends on the use of non-liver and liver-specific contrast agents. First, there are 3 main indications when to perform a liver MRI. It is a dedicated exam that takes often more than half an hour, and it can be burdensome for some patients. So first, you need a very good indication. There can be an incidental finding on the earlier examinations, for instance with CT over ultrasound. The second highly prevalent indication is the detection of HCC or cholangiocarcinoma in chronic livers. And a third indication can be the detection of liver mets as alternative for CT. These are in short the basic sequences that are used for MRI of the liver. These are the T1 weighted out of phase and in-phase images, the fat saturated T1 weighted images, the T2 weighted images with without fat saturation, and the diffusion images. The T1 fat set will also be used for the dynamic imaging after contrast injection. We learned last session that some typical findings in liver tumors can help us to make a reliable diagnosis. Some of these signs are presented here. You can go back in a previous lecture, which is stored in collective minds, to review these signs. I showed you also the importance of the in and out phase for detection of fat and iron, hence the fatty lady from Botero and the Iron Man. What are now the general things to be kept in mind when performing contrast-enhanced liver MRI? First, you need to scan in the late arterial phase, best by combining bolus tracking with multiple arterial scans. After this, the portovenous phase at 1-2 minutes. You will always need also a 3 to 5 minute scan. Here I'll show you the reason why to perform a late arterial phase scan instead of an early arterial phase on the left side. Only in the late arterial phase there's enhancement of the liver and the eventual tumors. So it is utmost importance to scan at the right moment. I think the best way to be sure that you always scan at the right phase is first by using bolus tracking, and secondly to scan multiple arterial phases. Furthermore, how can you be sure you are at the right late arterial phase? If there's initial enhancement of the portal vein, as shown by the red arrow. So if you see a slight enhancement of the portal vein, it's already enough to state it as a late arterial phase. So you're on the right phase. What happens now if you inject non-specific contrast into the arm vein? First, the contrast goes intravascularly in the arteries, and then intercellularly, also called the parenchyma phase. This is the organ enhancement phase due to contrast extravasation in the intercellular space of organs. When using a liver-specific contrast, there will also be an intracellular phase, but about this later. This is in short a graph of the intercellular phase of our organ enhancement. In bold red is an example of a hypervascular tumor that enhances more than the liver at the late arterial phase, followed by a washout, as is the case here. To speak of washout, there must first be a hyperenhancement phase followed by a hyperenhancement phase, which is lower than the surrounding liver. A lesion that remains hypointense during all phases does not, by definition, count as a washout. So here again, you need a combination of a hyperenhancement followed by a hypoenhancement. This hypoenhancement can be visible in the portovenous phase, but sometimes you have to wait until 3 to 5 minutes. This latter is typical for HCCs. At last, washout is a typical phenomenon of a malignant tumor. This is an example of washout of liver mets from melanoma. As you can see, this washout is typically already visible in the portovenous phase. On the other hand, this is an example of a HCC with multiple nodules in a non-cirrhotic liver. Washout is only clearly visible after 3 minutes. For this reason, remember always to scan until 3 to 5 minutes. So what do we see here now? It's a hypervascular tumor in red with a gradual increase of enhancement at 3 to 5 minutes. This is very typical for some specific liver tumors. Gradual hyperenhancement is typical for either fibrosis or sinusoidal dilatation. In both, contrast is accumulating gradually. Fibrosis is seen in FNH or cholangiocarcinomas. On the other hand, sinusoidal dilatation is a pattern typical seen in inflammatory adenomas. This is a very typical case of our intrahepatic cholangiocarcinoma with gradual progressive enhancement at 3 to 5 minutes due to fibrosis. This case 1 in collective minds, is a typical example of a benign tumor with central fibrosis, scar fibrosis, which is enhancing only on the late phase. This is some magnified views of the different phases with central scar enhancement. So if you have a homogeneous tumor with central scar enhancement, that's very typical for an FNH. And this is a typical case of an inflammatory adenoma. There are multiple. And this is a benign tumor secondary to oral contraceptives. The T2 hyperintense band gradually enhances in the late venous phase on T1 imaging. This band is also referred to the atoll sign, typical for inflammatory adenoma. Now let's go back to the enhancing graphs. This is what happens if you use non-liver specific contrast. What happens then if you give a liver specific contrast like Primulist? Then in addition to the intravascular phase and the intercellular phase, there's also an intracellular phase, more precise in the hepatocytes. So the liver will gradually enhance as are tumors containing hepatocytes. These tumors are, as stated before, the HCC or the hepatocellular carcinoma, the liver adenoma, and the FNH. However, apparently only FNH shows strong uptake as much as the surrounding liver. In very rare circumstances, also liver adenoma and HCC can show strong uptake. We will discuss this in a later session. Now a short notice concerning the transitional phase. This exists only if a liver-specific contrast agent is used like Primulist. The intensity of the liver and the tumor is influenced in this phase by all three components: intravascular, intercellular, and intracellular. This makes it very difficult to extrapolate previous knowledge of washout and gradual hyperenhancement at non-specific contrast to liver-specific contrast. And the second thing is that this can already be visible in the portal phase. So for this reason, diagnosis of washout and gradual hyperenhancement can be rather challenging when using Primulist. Finally, before we go to the casuistics, the indication statements when to use which contrast. Here again, the main indication for liver MRI. These are the differentiation of incidental findings. Secondly, the detection of HCC and cholangiocarcinoma in chronic livers. And as last indication, they indicate the detection of liver mets. For all these three indications, you can choose for either non-specific or specific contrast. The most benefit is in differentiation of an incidental finding like an FNH or adenoma. For chronic liver diseases, we prefer using non-specific contrast, but PrimoRisk is an acceptable alternative and is mainly used in the Far East. Due to absence of uptake in metastasis, PrimoRisk can also be used to detect the smallest mets. So, as conclusion, I would like to remind you what we have tried to teach you in this session. First and most importantly, most liver tumors can be diagnosed non-invasively by a dedicated liver MRI approach. Washout is a typical sign of malignancy. Sometimes a delayed phase, 3 to 5 minutes is needed. Gradual venous enhancement of the tumor is a typical sign of fibrosis or sinusoidal dilatation. First is a typical aspect of cholangiocarcinoma and scar tissue in FNH. Sinusoidal dilatation is, on the other hand, a typical sign for inflammatory adenoma. And last, PrimoRisk is a very helpful tool in liver MRI, especially due to the very reliable hepatobiliary phase. The transitional phase, on the other hand, can be challenging. Thank you for your attention. In this last slide, I would like you to show our current study group in Erasmus regarding primary liver tumors. Thank you very much. Thank you, Frederick, to introduce us again. Now we're gonna present and discuss two liver cases, and we're gonna do it in a way like we do it in daily practice. I will supervise Mira, who will go to the two clinical cases. So Mira, tell me what this case is about.
So this is the first case. It's a 32-year-old woman who uses oral contraceptives, and other than that, she has no medical history.
Okay.
So Martin told me to always look at the dynamic images first, so I already put them up. So this is the non-enhanced T1 arterial phase, and then the portovenous phases and later phases.
How does how many lesions do you see?
So the first lesion I noticed was this one.
Let's start with that one. Yes.
Yeah.
What's the characteristic?
So the lesion is hypo-intense compared to the liver on T1.
Mm-hmm. Heavily hypo-intense. Yes.
Yeah, exactly. And then when we look at in the arterial phase, we can see some enhancement here, peripheral.
Mm-hmm.
And when we have a look at the later phases, then the enhancement progresses inwards.
Yes.
I think it has a nodular pattern, yes. It's discontinuous. So I already had an idea what this lesion could be.
But wait. Before saying the diagnosis, it's quite a clear case, but we didn't look at the T2. We always look at the T1 and the T2. That's the most important sequences. So what do you see on T2 for this lesion?
Open the T2 for this lesion. So it's very hyper intense compared to the liver on T2.
If you have a very hyper intense, how do you know this is a T2 sequence, for instance, first?
Because on T2, when it images, the water is white.
Yes.
And if we look at the spinal canal, yes. It's very white.
So the lesion is very hyper intense, the same intensity as liquid. Mm-hmm. What's a differential diagnosis if you see a lesion like this on T2?
So it could be a cyst or a hemangioma.
Yes, the two main differentials, yes. Yeah. So now we have all the information together. We have the contrast. We won't look at the in and out phases. It's not of importance now. But what would be your diagnosis in this case? For this lesion?
I think this is an hemangioma because we saw enhancement after contrast administration, and a cyst doesn't show enhancement.
Okay, perfect. So this is a clear diagnosis of a hemangioma.
Yeah.
what did we give as contrast?
This scan was performed with multi-hands.
Multi-hands has the particularity first to have a normal dynamic phase like non-specific contrast, but has also a hepatobiliary phase after 90 minutes. Do we need that to confirm our diagnosis? To look at the 90 minutes for the hemangioma?
I think we don't need it in this case.
So we won't look at it. But the dynamic is just the same as non-specific contrast. So the diagnosis is clear. So now, what do you see else as lesion?
So I will put this one here again. So the next lesion I noticed was this big one in segments 2 and 3, which is slightly hyperintense compared to the liver on T1. And then in the arterial phase, I saw this arterial enhancement, which progresses actually in the later phases.
Yeah.
And after 3 to 5 minutes, it's slightly hyperintense compared to the liver.
So progressive hyperenhancement in the venous phase. What's the differential diagnosis if you have a lesion which enhances progressively?
So we can see this in fibrotic tumor like cholangiocarcinoma.
Yes.
In the scar of an FNH.
Yes.
But this is a whole lesion,
so not obvious.
No. And in sinusoidal dilatation in adenoma.
Yes.
Inflammatory adenoma.
Yes. And hemangioma also can harbor some vascular spaces, which enhances late.
Yeah.
So this is an hypervascular tumor with gradual hyperenhancement in the 3 to 5 minutes phase. So now the second step is we're going to look at the T2, of course.
Yeah,
again.
Open the T2 again. So what I noticed is that this lesion is slightly hyperintense compared to the liver,
Yes.
and it has heterogeneous appearance.
Yes, heterogeneous, but is it heterogeneous with a pattern or without a pattern?
I think it's a pattern.
Yes, and what kind of pattern do you recognize here?
Is this, well, there are some hyperintense areas in the lesion, and there's a hyperintense band.
Yes, and if you see a hyperintense band in a young woman.
Oh, that's suggestive of adenoma.
Inflammatory adenoma, yes. Yeah. And how is it called, this sign?
The atoll sign.
Atoll sign. It's a hyperintense band, and you can have some hyperintense islands in the center. So this is a quite straightforward diagnosis of an inflammatory adenoma, with gradual hyperenhancement in the delayed phase, in the 3 to 5 minutes phase, and a very specific pattern on T2. So since we gave multi-hands, let's look at the multi-hands, 90 minutes. So the hepatobiliary phase. What do we see?
So this is after 90 minutes. So this is weird because all the characteristics we just discussed were suggestive of adenoma. But you would expect the lesion to be hypointense to the liver and not isointense like we see here.
So that's kind of strange, no?
Yeah.
So you have all signs compatible with an inflammatory adenoma, but the lesion is isointense. That would make the diagnosis obvious for FNH.
Yeah.
That's strange. So what would you propose? Would you propose to the patient to stop oral contraceptives? And or would you do another examination to be sure? Would you prefer to do a biopsy, because the multi-hands is different from the findings on the dynamic phase? What would you propose?
Well, firstly, I think we need to be sure of the diagnosis before the patient can stop the oral contraceptives.
Yes.
But we want to prevent doing a biopsy, because if it's an adenoma, we have risk of bleeding.
FNH also. You have about 1 to 2% you can have excessive bleeding after biopsy. But what did we do in this situation? Because
So
it's an older case.
I think we need an MRI with Primovist.
Okay, we gave also Primovist in a second time. So could you compare the 90 minutes hepatobiliary phase of multi-hands with the 20 minutes of Primovist?
Yes. So on the left, the 90 minutes after multi-hands.
Where the lesion is iso-intense, yes?
Yeah, and then
No, below. Yes.
this
No.
one.
Yes.
Yeah, this is.
And here,
Primovist
how
after, yeah.
does the lesion look like?
So this is more like what we expected.
Yes.
So the lesion is now hypo-intense compared to the
So-
surrounding liver.
So I think that it's a true positive and is indicated by the use of Primovist. Why do you think that the multi-hands has a false negative finding? So a finding more specific for FNH. So iso-intense. How come do you think?
I'm actually not sure, because to me it's very interesting that the lesion is iso-intense after multi-hands and then hypo-intense compared to the liver.
Mm-hmm.
But maybe it's due to the signal intensity without the contrast.
Well, first you see that the enhancement of the liver in the hepatobiliary phase on the right side is much brighter, more hyper intense. That's because the uptake in the liver, in the hepatocytes, is 50%, and with multi-hands 5%. So you get less enhancement of the liver on the left side. So, and if the lesion is already hyper intense before contrast on the left side, if there's no enhancement in the hepatobiliary phase, it still can be iso-intense. So he's put the T1 before contrast of multi-hands.
This one.
Yes, and
this one.
So here you see the lesion is already hyper intense before contrast. So if you have enhancement of intracellular uptake in the hepatobiliary phase of the liver and not the lesion, then it still can be iso-intense, and that's a pitfall when using multi-hands. Okay, but let's look also to the now the transitional phase. So let's look at the 3 minutes phase with Primovist. So this one, yes.
Oh, so this
and
now
look,
shows washout.
yeah,
This
this
lesion.
looks like washout. And if you look at the multi-hands, when you're using multi-hands in the venous phase, the late venous phase.
So portovenous.
Yes, this one, yes. There you see the hyperenhancement, and it's much lower on the left side when using Primovist. It's a pseudo washout. You understand? So it's not a real washout, but it's a liver which is enhancing already in a transitional phase. So it's a pseudo washout, and it's quite typical when using Primovist. And for that reason, the 3 minutes phase is called also the transitional phase. So it's somewhat different to analyze. So, and if you know it's another enhancement, you know the image on T2, you're sure it's a hemangioma. So in most of the cases, it's not a really diagnostic problem, but you have to be aware this is not a real washout. Okay.
Okay. Clear.
So that's for this case. I think there are some more lesions in the liver, but that's the two most important. So let's go to the second case.
Okay. Perfect. So I will open the second case now.
What's about this case? What's the clinical background?
So this patient is 68 years old and has colorectal cancer. And the patient was included in the Camino study, which is a multi-center study in which they assess the difference of normal CT versus MRI Primovist for the detection of liver mets.
Okay. Detection of the number of mets is to look if the number is different. Yes. And why is that so important, do you think?
So I think it's important because a few years ago, multiple liver mets meant that there were no treatment options.
Yes, yes. And now there are still enough treatment options. If you have multiple mets in the liver, and still local treatment has still benefit if there are more lesions than 5 or 6. So that it's very important to know how many lesions there are and where the lesions are available.
Yeah.
So
okay.
This case, they did a CT.
Yeah. So they first performed the CT. So I will show that to you first. The first lesion I noticed was over here. So hypodense lesion.
One lesion. We have one lesion on CT.
I think maybe there was. Yeah, there was another one over here.
Yes. Segment 8.
And then
segment 3. 3 lesions.
Segment 3. Yeah.
Any more?
No, I think I saw 3 actually on CT.
So CT, that's CT. So based on this, we could do 3 radio frequency relations.
Yeah.
But let's look. They did also a Primovist. So look, take a side by side. Look at the Primovist 20 minutes and a CT.
Primovist 10 minutes, 20 minutes.
Okay. Normally 10 minutes would be enough, but we did also here 20 minutes. In cirrhotic livers, we prefer always to do up to 20 minutes because the enhancement of the liver is slower. So the hepatobiliary phase is slower and lower.
Okay. So
how many lesions do you see now on MR?
So we recognize the lesion we saw on CT over here.
And why it's not an hemangioma? That was because the CT before there were no lesions in the liver.
So the lesions were all new.
Yeah,
so
new,
that's
perfect,
suspect.
yes.
Yeah.
Okay.
Okay. And this lesion over here, we also detected with CT.
Yes.
Over here.
2 lesions.
And then the one over
3
here
lesions.
was also recognized.
Yeah.
On MR.
Okay.
And I noticed actually over here.
We already have 4 lesions now.
Yeah.
Do we see it back on CT?
So
it's more gradually. Not really, yeah. It's difficult.
No, it's difficult to detect. Yeah.
Maybe it's here, I think.
Yeah.
Okay.
Yeah.
So in retrospect, there are 4 lesions on CT.
Yeah. Okay, and I didn't recognize another lesion.
You
on
sure?
This sequence.
You sure? There's not so easy to look at.
No.
So what I do in these circumstances, I always look also, and it's very important to for the number of lesions detection. That's to look at the T2, multi-shot, and the diffusion. So let's first put the okay, that's fine.
So CT.
No, not the CT. So the T2 multi-shot. Yes, instead of the CT.
Okay. Yeah.
Yes, and then the Primovist 20 minutes. Yes, and the diffusion. IB value.
Yeah.
I think this is okay. Now already you see. So if you use those 3, you have the highest sensitivity. Is my opinion. So
okay.
We have the 3 lesions. Now you can look at the T2, but multi-shot on the left side. But let's look. It's easier. That's my impression. To look at the diffusion. There. Look at the lesions. How many lesions do you see here?
Okay, so we recognize this one again,
yes,
and this one over
again.
here.
The third one, yes,
and the third one, and
and
this
there?
one
okay.
was the one who we saw over here as well. But now,
Do you see more?
So here is
That's a very
some
small. Let's look at the T2. Is there something happening there? Can you enlarge the view?
Yeah, so
It's small, yes.
this spot over here should be over here.
Let me take a look. Why that's not clear for me? I would not make this positive.
This.
Here there's a small white
that's
spot.
another one.
Can also be a susceptibility artifact, but let's look at the T1. There could be something here. You see the lesion here, T2.
Yeah.
Here.
Okay, so this is another small.
This is for sure another metastasis. Yes. And then let's go further. This here. So we really have to look at every small pixel to know if there's something corresponding on the other sequences.
Yeah.
For instance, here a small, is that a lesion? Not really, yeah. Do you see any other lesions?
I don't think so.
So that,
you already saw
yes,
those two,
yes.
yeah.
Maybe this one, there's also a spot here.
Yeah.
Oh, yeah, you look. First we saw this one, but if you look closer here, can we take a closer, this one? There's a small lesion, a very small lesion here.
Yeah, and it's
You
also
see?
visible on the T2, this
Yeah.
one?
Let's take a look.
Okay, yeah.
Do you see
You
it
can
there?
already see
Yes,
this.
yes. So it really helps if to look at all the three sequences. To look at the T2 multi-shot, not a single shot, because there's less blurring when using a multi-shot. The diffusion and the Primoris. So that would be my proposal. If you have to detect liver mets with MR, use Primoris and look at those three sequences.
Yeah.
Yeah,
and this detection is better than CT.
Yes,
CT.
and if it helps, if it is cost effective, that will future studies will show that. Okay, that's it.
Perfect. So
Thank you very much. Well done. Thank you very much, Frederick. Bye.